This week on The Source, and especially today, we've been focusing on healthcare in Niagara. We once again welcome Dr. Sriharsha Athreya. He's the head of interventional radiology and oncology at Niagara Health. And Doctor, our last segment with you back in 2022 was so popular, we wanted to have you in again. We're talking about interventional treatments, and really here in Niagara, we're one of the few hospitals doing some of the things that you specialize in.
Yeah. That's right, Mike. Thank you for having me. And Happy New Year to you and all your team and viewers. This intervention radiology is, we are basically radiologists, but specialize in interventions, meaning doing procedures. And how we do it is basically use image guidance, X-ray guidance, ultrasound guidance, MRI, CAT scan, and do certain minimally invasive procedures, which we, it could be a biopsy of a tissue or a lesion within the lung or a liver or things like that, to a complex, what we discussed last time around, a tumor ablation. And in between, there are various other repertoire of cases which we do, certain like angiogram and embolization. I thought we could probably focus a bit on embolization and discuss what it is about.
Under what circumstance are you looking at focusing, is this in the emergency room, where we're talking about embolizing something that is bleeding internally?
Yes, so embolization basically means to stop the blood flow to an organ or to a system, and that's how to explain in simple terms. How do we stop the blood flow is either by cutting open and tying from outside to stop the blood flow and tying the vessel, or surgically, or what we do, specialize in intervention, is use image guidance, slip in a plastic tube called the catheter by doing an angiogram. We do angiogram more prominently or more commonly done through the artery in the groin. And we do the angiogram and use the image guidance to check where the bleeding is, and then do certain further techniques to stop the bleeding. To your question about when do we do embolization, it's a combination of both. When patient presents acutely ill, for example, internal bleeding. It could be an ulcer bleeding, and patient does not respond to endoscopic measures, and he or she still continues to bleed. That's when we do angiogram of the internal arteries and then block them internally with certain coils and particles, which I'm going to show you shortly.
Can we look at some of the
items
that you brought today?
We just discussed about the bleeding, the embolization for bleeding. Once we do an angiogram, we advance the microcatheter. You can feel it. This is the microcatheter, which is about 2.8 French, we call it. That's how we measure it. French divided by 3 gives you a millimeter.
Okay.
So this is about a millimeter catheter we advance into the vessel and do an angiogram to see where the bleeding is.
So this is going right into the blood vessel?
Right into the blood vessel where the bleeding is, and then we stop.
And as you're doing that, you're also looking through a device that's showing you where it's going, what it is coming into contact with.
That's right. We do the angiogram. That's our roadmap, and we see that on the X-ray, the TV screen, which we see the live image of where the bleeding is.
Right.
And then we use certain embolic agents, which we call it. And particularly in this kind of scenario where it is bleeding, we use coils. Coils are devices of metal, usually platinum based. They're covered with some fibers.
Right.
It causes mechanical blockage to the vessels. Once the blood flow slows down, there will be more clots forming. When the more clots form, further clots form, and that's how we stop the bleeding.
So the blood gathers around that coil and
that's right.
really just sort of sits there and clots itself.
Correct. And then the coil acts like a mechanical barrier. Whenever there is slow flow, the natural tendency for the blood flow within blood vessels
hits that barrier
to stop.
And just stops.
And if you see this, this is what we advance this tiny catheter through that microcatheter and deploy the coil. It's coming out to the end of the wire there.
And there's your coils.
That's the coil. And it's completely out. And if I'm happy that it's in the right place, and then we can release it. Right. These are specialized coils. They're called a detachable coil. That means it's precise and it's controlled. I can only deploy it when I know, yes, I'm in the right place.
Now this is the end that's being put into the blood vessel.
Yes, this is once we deploy it, you only see just the the floppy
Right.
coil which gets deployed in the artery.
And from your end, you're actually holding on to a thinner wire that pushes that coil out.
This is the wire.
Right,
We push it out.
right. Wow.
And once it's out, you can feel it. This is how the coil would look
Right. Okay.
inside, and it forms.
It just seems such a simple procedure, but it's not.
Yes, it sounds. Yeah, you're right. Yeah, it's highly skilled because we need to be precise at where the bleeding is, and I call it closing the front door because that's where you need to be there, and then coil it internally within the vessels to stop the bleeding.
How long does one of these procedures take?
It's variable, depends on anatomy of the patient condition, how stable, unstable, what's the bleeding like, which artery in the vessel. I would say about an hour, sometimes 90 minutes, sometimes sooner. So I would give at least 90 minutes just for the actual procedure itself, sometimes longer.
Is that much faster than the other option, the more interventional, or I should say the more invasive option?
The invasive options is always there because surgically, obviously, if it's say for example, an ulcer bleeding and we can't stop bleeding through endoscope or
Right.
through coiling, then patient has to go through surgery, and it comes with its own advantages and risks. But this is the best way to try it out initially, and if it stops the bleeding, which it does most of the time, and it saves an invasive surgery after that.
Is this something that happens often in the emergency room, in the ER, when someone's been in an accident, for instance, and there's some internal bleeding?
A good point. Yes, it can be, embolization can be used for patients with trauma, particularly single organ injuries, such as say patient was in a bike, fell and ruptured the spleen or whatnot, is still stable, doesn't need an emergency surgery and whatnot. These are the patients which we can do angiogram and see where the bleeding is and put in the coil to stop the bleeding. It saves the life, the blood transfusion, the surgery, everything comes with it.
In your department, how many doctors are skilled enough to do one of these procedures?
We are 4 interventional radiologists. We are fellowship trained, specialized 1 to 2 years of fellowship trained interventional radiologists. And it's a good team we have. The thing is, we focus on the interventional radiologists, but we tend to forget on the other team members, particularly our medical radiation technologists and the IR nurses, who, similar to what happens in the OR, they perform the same role of
Right.
assisting us, which I won't be able to do it myself, getting the catheter and all that, unless I have our medical radiation technologists, the MRTs, who are helping us with it, the nursing staff, making sure the patient is comfortable, checking the vitals, maybe give some conscious sedation, because this is the patients are done under conscious sedation, doesn't
Right.
have to be put under.
Right.
So it's a nice teamwork, which happens within the angio suite.
How new is this technology?
This has been for decades. The angiogram and embolization for decades across the globe, and it's well-established practice, offered for both emergency scenarios like trauma or internal bleeding. We also do this procedure for certain benign conditions like fibroid, uterine
Right.
fibroid, patients who have symptomatic fibroids with heavy bleeding and whatnot. They cannot have surgery, hysterectomy, and they don't want surgery. Or they've read about this fibroid embolization, which offers similar outcome compared to surgical alternatives. In selective group of patients, we treat them with embolization. And what we use that for are the particles.
Right.
It's the PVA particles. They are, if you look at the size of it, which says 300 to 500 microns,
Right.
that tiny particles, we inject them through the catheter, and this does the same job as the coil,
Right.
that is both mechanical as well as pharmacological, that it blocks those arteries, decreases the blood supply to the fibroid, and over the course of time that shrink.
That's fascinating. Doctor, we're looking forward to your next visit as well. Thank you for sharing some of this with us today.
Thank you very much, Mike.